This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals, Inc. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines.
Hi, I'm Rob Su. I'm going to take you through HRCT and some basic chest CT anatomy. All right, so let's start with this HRCT that I have pulled up here. So if we look at the components of HRCT, we see that the basic protocol that we have is that we have inspiration, we have expiration, and we have prone imaging. And those are the three components that make up the HRCT protocol. Now let's look at the inspiratory images and look at the technical parameters associated with HRCT. So first of all, these are thin sections at 1 millimeter. And so you can see that as we scroll through, we're looking at 1 millimeter images. Now, of course, this can be even submillimetric, as you all know. The other component of HRCT is that we have what we call an edge enhancement algorithm for reconstruction, or what we call a kernel here. And this is designated as B46. And so this sharpens the edges, because what we're interested in HRCT is spatial resolution, being able to see the patterns within the lungs. And the final technical parameter we have here is the display field of view, or what is known as DFOV. And here it's 29 centimeters. And what this represents is that it really is a collimation or focusing just of the lungs. And so you can see that we've cut out a lot of the edges of the patient's soft tissues in favor of focusing really on the lung parenchyma, which is really the basis of why this HRCT was ordered. So in addition to the sequences that I've already shown you, we also have coronal and sagittal reformatted images. And for diffuse lung disease, the coronal and sagittal reformations really help you figure out where the predominance of the abnormalities within the lung are. So I'm going to just scroll through the HRCT on the inspiratory images. And what we see is, first of all, are the lungs. And just for orientation, we have the right lung, which appears on your left, and we have the left lung, which appears on your right. We can see that these small white dots and linear structures are blood vessels within the lungs. So here we see a number of ring-like structures, and these are airways. And these are airways that we're cutting through as we scroll from the top of the lung to the bottom. And we can see that there's a thin airway wall. And within the center, you see a very dark area, which is the air contained within the airway. Now, notice that some of the white dots, as we talked about earlier, that represent blood vessels, some are intimately associated with an airway. And so this is a pulmonary artery that's associated with its accompanying bronchus. And the other areas, or the sole white dots, I should say, are pulmonary veins. So as we scroll from top to bottom, we can follow these structures as they head centrally to what we call the hilum. And here we can see that the airways are now joining as we go more inferiorly. We can also see the blood vessels doing similarly as well. And now, if we look at more of the central structures of the chest, we can see that there's the trachea. And as we follow this structure inferiorly, it divides into the right mainstem bronchus and the left mainstem bronchus. And as we move a little more inferiorly, we can see the right upper lobar bronchus going into the what we know as the anterior segmental, the apical posterior segments. And as we move even more inferiorly, we can see that now this airway is known as the interlobar bronchus on the right. This is still the left mainstem bronchus. This is the left upper lobe bronchus taking off here. And we can see again the segmental bronchi. And as we move inferiorly, we can see the left interlobar and left lower lobar bronchus as well. And you see another airway as we go on back to the right. We see this dividing into the right middle lobar bronchus. We see a very short right lower lobe bronchus going into a superior segmental bronchus of the right lower lobe, a common basal segment. And we can see anteriorly, again, the division of the right middle lobar bronchus into the lateral and medial segmental bronchi. The anatomy is similar on the left side. And again, we can see the superior segmental bronchus coming off on the left. We can also see the common basal bronchus, and we can then see the segmental bronchi here, similarly on the right side as well. Now, what we're looking at are the lung windows, and in this setting, we're appreciating what is actually taking place in the lungs. But if I switch the settings here and go to the soft tissue windows, what we use this setting for is to look certainly at the blood vessels, but we can appreciate the structures of the mediastinum. And so if I go back up to the top and come down, we can again see the trachea. We see adjacent to the trachea, we see the thyroid gland. And as we move into the chest, we can see the left brachiocephalic vein. And this joins the right brachiocephalic vein and becomes the superior vena cava. Here we have the right brachiocephalic artery, the left common carotid artery, and the left subclavian artery. Now, with HRCT, we don't want to give intravenous contrast. And so, of course, these structures are going to be a little harder to see because we're not outlining them with the intravenous contrast. This is the thoracic aorta in the aortic arch, and we see the ascending aorta and the descending aorta. As we move inferiorly, and again, just to orient you, we're going to, let me just switch windows here back to the lungs. So we're back at the carina, which is the division of the trachea into the right main stem and the left main stem bronchi. Now, when I switch to the soft tissue windows and we go just a little bit more inferiorly, we still see the ascending aorta, and here's the main pulmonary artery dividing into the right pulmonary artery and the left pulmonary artery. The left pulmonary artery travels over the left main stem bronchus, and you can see that here as well. Just to, I guess, round out the anatomy, here again, as I mentioned, is the superior vena cava, which brings blood back to the heart. Here we have a vein that's known as the azygos vein, which travels over the right main stem bronchus, just to give you an idea here. And the superior vena cava then can be followed all the way back to the right atrium. Now, as we move closer to the base of the lung, what we see, or the chest, we see the heart chambers, which are very hard to delineate without intravenous contrast. But just to give you an idea, this is going to be the right atrium, the right ventricle, which is most anterior. Then we have the left atrium, which is in the back, and we have the left ventricle. And as we scroll again to the lower part of the patient's chest, we see the base of the heart, and we see the descending aorta. Now, other structures that we've not yet covered is that behind the trachea, we see the esophagus, and you can see that the esophagus has a little bit of gas and sometimes a little bit of fluid, and you can follow that structure completely through the chest. And again, here's the esophagus here, and we're following that, and it travels just through the entire chest, through the esophageal hiatus, and then into the stomach. This large organ that we see here at the base of the chest is the liver, and on the left we have the spleen. And again, this is food, secretions, and air within the stomach. Now, all of this white areas around the edges, as you can imagine, this represents the bone. And so here's the thoracic spine, and here are the ribs. And I've just switched over to the bone setting so you can more readily see the skeletal structures of the chest. And again, this is the thoracic spine and the ribs, and here's just the sternal body. And the remainder on the outside is just the soft tissues of the chest. All right, now let's cover a little bit more anatomy. And I'm going to just scroll down here to, again, we're at the top of the chest. And I'll show you the lobes. So at the very top of the chest, we have the upper lobes, the right and the left. And as we scroll more inferiorly, and again, this is just for orientation, this is the trachea. And if we switch over to soft tissue windows, this is the thoracic aorta or aortic arch. And as we move inferiorly, you see these linear structures appear. And these are known as the fissures. And here is the major fissure on the right, and here's the major fissure on the left. Now, as we scroll inferiorly, we can see that now we're seeing the right lower lobe as well as the left lower lobe. And the fissures are again dividing the upper lobe from the lower lobes. And here's again for orientation, we're at the level of the right mainstem bronchus and the left mainstem bronchus. And as we move more inferiorly, we can see that there's almost an area here that's devoid of markings. And this is when we pass from the right upper lobe across the right minor fissure into the right middle lobe. And so because the minor fissure travels in a more horizontal plane, we don't cleanly see it or see it as this very nice linear marking that we see with the major fissures. So here we've got all three lobes, right upper lobe, the emergence of the right middle lobe, and we have the right lower lobe here. On the left, we have the left upper lobe and the left lower lobe here. Now, one thing that's sometimes a little bit confusing is that on the left, everybody talks about the lingula, which in most cases is not its own lobe, but a portion of the left upper lobe. And one easy way to sort of figure that out is to look at the airways from central to peripheral. So again, for orientation, let me back up. This is the left mainstem bronchus. And as we follow this, we'll see that the first airway that comes off and heads a little bit superiorly if I move up on the patient's chest. And this is the left upper lobar bronchus. And notice if I head a little bit more inferiorly, that airway seems to continue. But this is really now known as the lingular bronchus. And we can see that as we go more inferiorly, that this lingular bronchus feeds the lingula, which is again, in most cases, just part of the left upper lobe. So at the bottom of the chest, we now see the right middle lobe, we see the right major fissure, and we see the right lower lobe. On the left, we see the bottom of the lingula, and we see the left major fissure and the left lower lobe here as well. Let's look at the coronal images here. And so this is as if we're looking at the patient from their front and looking into the lungs. And what we see as we come into the chest from anterior, from the anterior aspect, we see the right upper lobe and the right middle lobe. And we see the left upper lobe and lingula and a little bit of the major fissure and the left lower lobe. Now, if I switch over here to the soft tissue windows, we're seeing the front of the heart here. And as we move posteriorly in the patient's chest, we see again the fissures. So we see the minor fissure, major fissure. So we have right upper lobe, right middle lobe. Now, as we get more into the posterior part of the chest or the middle part of the chest, we'll start seeing the lower lobes. And we can follow these back all the way. And here we see a very nice example of the trachea dividing into the right mainstem bronchus, left mainstem bronchus. The first bronchus to come off the right mainstem is the right upper lobe bronchus. And at that point, this bronchus, after the takeoff of the upper lobe bronchus, is known as the intermediate or interlobar bronchus. And on the left, we have the left mainstem bronchus, which generally is about twice as long as the right mainstem. The first branch off is the left upper lobar bronchus. And then we know this portion, this short segment, to be known as the left interlobar or left intermediate bronchus. And then we see the lower lobe bronchi heading inferiorly. Again, as we move to the back of the chest, we see the spine. We can see the right major fissure, left major fissure. So that's dividing the right upper lobe, left upper lobe from their respective lower lobes. This is just the diaphragm, which again appears as a thin muscle layer. Often it may be very difficult to discern a true diaphragm on axial images, given that it's abutting the similar density um, liver and spleen on their respective sides. Look at a little bit more closely the HRCT parameters and see what we can sort of pull out from this. So I'm going to switch over to, first of all, as we just went through the inspiratory, but let's look at the expiratory. So please keep in mind that when we do expiratory imaging, the patient is asked to fully exhale. And as air leaves the lung, it becomes grayer. And it has what we call a gravitational grayness that I'll show you here. So as we go into the expiratory images, first of all, compared to the inspiratory images that we have on the left side of the screen, you can see that the expiratory images are grayer. And this is roughly the same level, right? And you can see if you compare the right lung to the right lung, left lung to the left lung, you can see that the overall lung appears grayer on the expiratory images on your right. What you also notice, and one way to readily tell if you're dealing with an expiratory image, is to look at the trachea. And so here you can see on the inspiratory images that the trachea looks ovoid with a rounded posterior tracheal wall. If you compare that to the trachea seen on the expiratory imaging, you can see that now it's flattened or even concave. So it looks like more like an omega sign, if you will. And this is one easy way to note whether or not you're dealing with an expiratory image. So I'm going to just scroll down a little bit more inferiorly. And again, just to orient you, we're at the level of the right and left mainstem bronchi. And again, if we look at the lung parenchyma, you can see that it has this grayness through it. And just like the posterior wall of the trachea was a bit bowed or concave, also the back walls of the mainstem bronchi, as well as the larger bronchi more inferiorly, will also demonstrate the same appearance. Now, let's go a little bit lower. And I'm going to just move or scroll down to a relatively same level on the inspiratory images as well. And what we see here is this sort of great gravitational dependency or this grayness. And so the patient is laying on their back, and on expiratory imaging, as I mentioned, the lungs look gray. But notice as we go from the front side of the patient to the back side, that the lung becomes grayer, grayer, grayer. And then we skip over what we call the fissure that separates out the lobes. And then the lung becomes a little bit darker, and then it becomes gray, 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 to where it's at the most gray at the very or most dependent or posterior dependent portions of the chest. And this becomes pretty obvious as we go inferiorly. As you can see, it's gray, certainly anteriorly, but as we approach the fissure, the middle lobe, it becomes grayer. And then we jump over the fissure into the lower lobe, and again, it becomes fairly gray here. And we can see that as we get to the back of the lung, it's its most gray. And this is what we mean by gravitational dependence. Now, notice that we don't see any dark areas or areas, the lungs look pretty uniform, I should say, or homogeneously gray. Now, you do see some little areas that appear a little darker, if you will. And again, you can see that here and here, or I should say these areas don't nearly appear as gray as the adjacent lung. And these are small areas of air trapping. And we can all have areas of air trapping that are physiologic, but again, it's fairly small areas such as this. But overall, when we scroll through the expiratory sequence, we see that it's mostly homogeneous and gray with a gravitational dependence. All right, so let me compare and contrast what we saw as a normal expiratory sequence with an abnormal one. So here on your left, we have, again, inspiratory high resolution images. And I'm going to just kind of scroll through this so that you can just get a flavor for it. It's really, to the casual eye, there's really not too much that appears abnormal, but I'll point out a few areas and you can decide for yourself how abnormal it might be. So if you look very closely, you can see these areas that appear just a little bit blacker. And this is admixed or immediately juxtaposed to areas that look a little bit grayer here. Now, if we look at the right screen with the accompanying expiratory images, and again, we know that these are expiratory because one, the lungs are grayer, and two, as we mentioned, that the posterior wall of the trachea is a bit bowed. Now, I'm going to take this to about the same level as we see here. And again, if we think back to what we saw on the normal expiratory imaging, one, you can see, first of all, you can see that there's a lot of patchiness to this. And there's very dark areas admixed with areas of gray lung. And with that, you can see that there's some very geographic margins accompanying that. And interestingly enough, if we compare roughly the same level, we can see that those areas that I pointed out that appeared a little bit darker or more lucent correspond to these areas that seem a little darker on the expiratory imaging. And the gray areas that I pointed out previously all have also appeared grayer. And so when we see this in the sense that the gray and dark areas from the inspiratory imaging become more noticeable on expiratory imaging, this is a case of air trapping. So these dark areas are holding on to the air while the gray areas are forcing out the air and becoming grayer. And so here's just a really nice example, especially in the right lower lobe here, of significant small airways related air trapping. Let's look at the next sequence that we'll focus on is the prone imaging. It's important to include prone imaging in an HRCT sequence because it alleviates or takes away the posterior dependent atelectasis that may sometimes mask subtle interstitial lung disease. And this is particularly important in early disease or in cases where screening is necessary to detect early interstitial lung disease. So here I'll just show you the patient lays on their stomach and we're just going through the cuts here. And we can see that, again, pretty normal here. And we can see that the lung looks pretty normal here as we scroll all the way down to the base. Notice that what we call the pleural parenchymal interface, meaning where the lung touches the pleura or the edge of the lung, looks very smooth and there's no jaggediness or serrations to that. Okay, so let me jump to what I'll show you as why this is important. So this is an HRCT on a different patient, and I'm going to scroll down to the area of interest. And as we get to, again, for orientation, I like to use the tracheal bifurcation or the main stem bronchi and the carina for an easy to identify landmark. Now notice that we see along the posterior dependent portion of the chest, there's a lot of grayness here, and there's some irregularity of that interface. So if we look anteriorly for comparison, we see that the lungs touch the edge of the chest or the pleura, and it's very smooth. But notice here, it looks a little bit irregular, and we have some abnormal density. And as we go more inferiorly, so now we're within clearly within both lower lobes here. We can see that this abnormality looks more obvious. And we can see, again, a lot of grayness. We see that the pleural parenchymal interface is somewhat distorted. And as we, again, go to the level of the diaphragm and the base of the heart, we see that that continues. Now, one might think, if you look at this, especially if the indication for the HRCT was shortness of breath or rule out interstitial lung disease, or perhaps this was a patient with autoimmune disease, and again, it was done for this HRCT was done for screening, that one may start to think, well, maybe this represents early interstitial lung disease. Now, this is really a really prime example of why prone imaging is important in these cases of subtle disease. And so let me take you back to the right screen where we have the prone images. And the patient, when they do prone imaging, they take the techs are instructed that when they put the patient on their stomach, before that, they take a number of big, deep breaths in so that their lungs are fully inflated, and then they get on the table, and then the prone imaging commences. So here, if we look at the lower lobes in the prone position, you see that as we scroll down, all of that grayness that we saw on the edges, as well as the irregularity of that interface between the lung and the pleura, is now gone, right? So every image that we look at, despite what looked to be a reasonable degree, although pretty subtle on the supine images, have really vanished on the prone images. And so when we look back at the inspiratory images, we can conclude that this was all just posterior dependent atelectasis because the patient was laying on their back. And again, this is why, once again, that the prone imaging is key so that you don't overcall this or confuse this with early interstitial lung disease. In this day and age, we're very dose conscious in terms of how much radiation that the patient receives. And all of the protocols have been designed to reduce or limit the amount of radiation that the patient receives. This coupled with the more modern scanners that can set a threshold dose. So in this case, what we're doing is we're doing the optimal dose for the inspiratory imaging, and then for the expiratory and prone imaging, we reduce the doses. Now, it's important that you give enough dose, however, to be able to image the lung to recognize or to be able to detect interstitial lung disease. And the type of, or the very extreme or ultra low doses that we tend to use with screening CT for nodules is not optimal for HRCT. So if we look at, again, this is the case that I showed you earlier, and just so that you get a feel for what an optimized dose looks like. But I'm going to take you to another example here. And we're going to just focus on this image or these two images. And if on your right, we have a screening CT. And so this is really ultra low dose. And we can see that the MA here is only 23. And on your left, we have the HRCT. And we can see that if we look at the dose here, it's at 144. So, noticeably higher. Now, what I'm going to just point out is this one area, and hopefully you can appreciate the difference here. So if we look at within the right lower lobe in the posterior part, we can see that on the extremely low screening dose CT, we see that there are some reticulations here. And by that, I mean some linear markings or lines that are at the edge of the periphery here. And these are blood vessels, but you see some lines here, perhaps, right? Now, if you look at that same area on the HRCT that was done later, we can again see those same blood vessels, but notice that first of all, the blood vessels look a little sharper and a little bit easier to see. But notice the abnormal lung, or those reticulations and small little nodules, are much more obvious on the standard dose HRCT compared to the low dose screening CT. And again, if you were to do your HRCTs in this extremely low dose, you probably would undercall disease or not be, in some cases, not be able to detect it at all. So, in closing, I hope you found this helpful, going over HRCT, some of the technical parameters, as well as the sequences, and a little bit of normal anatomy. Thank you for listening.